Good evening, everyone. Welcome to my IVF and our webinar tonight. And I'm very pleased to have another special guest. Dr. Esther Marbán is with us. And she is with us, I think it's our fourth or fifth time. I don't remember exactly, but it's always a great pleasure to have you here. And I always remember our webinars. Usually you have lots and lots of questions. It's going to be an interesting session, I am sure, as well. So welcome back. It's great to have you here. How are you feeling tonight?
Hi, Caroline. I'm really happy to being here today, and I hope to have a really interesting topic to our patients, and I will be waiting for all the questions as usual.
Yes, of course. I'm sure there will be plenty of the questions. And of course, tonight we are definitely having a topic that brings lots of questions. It's the most common topic that brings those questions. So it's no wonder that our patients want to ask. So remember, as always, we will start with the presentation. Dr. Marbán will be talking about advanced maternal age. She will provide the case story, of course, her past patient, and of course afterwards it will be time for your questions. All you will need to do is just type those in the chat section. You can do it during the presentation or later on. And then Dr. Marbán will answer them for you. So don't hesitate. If you ever been in our previous webinars with Dr. Marbán, you probably know that she always takes time to answer. So really, this is a great opportunity for you to have to ask and of course get some advice as well. Let me just mention that of course my IVF we are part of European Fertility Society, and as you know, our main focus this webinar sessions are focused on success stories, the various topics, but we are definitely here to bring you some success stories. And of course, tonight we will talk about this as well. So I'm already looking forward to that. And I guess that will be it from me. Let's get going with our presentation. Okay, Dr. Marbán?
Okay, thank you.
Excellent. Thank you so much indeed. Let's go.
So good evening, everyone. I'm Dr. Esther Marbán. I'm gynecologist and I'm specialized in reproduction. And I work at Clinica Tambre fertility clinics in Madrid. Oops, here we are. So today we are talking about single embryo transfer at advanced maternal age and how to succeed. So in this slide, you will see what we'll cover, and you will be following all that important points. So let's start defining what's advanced maternal age. So advanced maternal age is typically defined as getting pregnant at 35 years old or older. We know that the egg quality and also the ovarian reserve decrease as age increases. The chances of carrying a baby also with chromosomal disorders, such as Down syndrome, could also increase. So when we talk about advanced maternal age, it's important to consider the risks that the fetus could carry and also the maternal risks. If we talk about the fetus, it's important to know that the risk of having a miscarriage, also a stillbirth, and also abnormal growth are related to age. But also the maternal risks are going to be increases. We talk about high blood pressure, diabetes, and premature birth. That's the reason why it's recommended, if possible, and we will talk about that afterwards, to have, if possible, a single embryo transfer to avoid those risks that are even higher if we talk about twin pregnancies. The case we are presenting today is a couple that came to our clinic. They were trying to conceive for around 1 year. She was 41 years old. Her weight was 49 kilos. She didn't have any previous IVF attempts, no diseases or current medication at that moment, and the all important familiar background to consider that's her grandmother with father's side suffered from breast cancer. Her partner was 42 years old, no diseases or current medication at that moment, and he didn't have any familial background. So we started doing the diagnosis. When we talk about the male diagnosis, in that patient, we found that he had oligospermia with a concentration of 8.1 million per milliliter and a total concentration of 28 million. The total motility was 62% and the morphology was completely normal. He also performed a testicular ultrasound and a Doppler that came back normal. We also tested the karyotype, which was completely normal, 46 chromosomes, 1 X and 1 Y chromosome, according to a normal karyotype in a male. We also did the infectious diseases screening, and we also tested the DNA fragmentation test regarding the single and double-stranded DNA fragmentation that also came back normal. When we talk about the male diagnosis, and as I mentioned previously, we did the DNA fragmentation test. That DNA fragmentation test tried to check if there is any kind of DNA damage in the sperm. When we find a high rate of single-stranded DNA fragmentation, it could be related to a lower fertilization rate of the eggs that we will retrieve afterwards in the egg retrieval. Apart from that, when the double-stranded DNA fragmentation is found, it's possible that we may find a higher chromosomal alteration in the embryos, and it's also possible to have a lower rate of developing embryos into blastocyst stage. As a result, it's possible that DNA fragmentation is related to a lower implantation rate. But what can we do in these patients? We always recommend stop smoking, drinking alcohol, and we try to make our patients reduce the tea and coffee intake. It's also recommended to take antioxidants and also turmeric, which are quite powerful antioxidants and could help us in reducing that DNA fragmentation. But apart from that, it's important to use specific techniques during the egg fertilization. The technique we use is called fertile tip, and it reduces the chances of selecting a fragmented sperm to fertilize the eggs, which in the end is what we want to try. Regarding the women, we tested, of course, the ovarian reserve. We did an AMH, an anti-Mullerian hormone, that came back 0.5 nanograms per milliliter. We also we did a vaginal scan with antral follicle count with a result of 3 antral follicles in each ovary, a total of 6 follicles in between both ovaries. We also tested the karyotype, which was also normal. The gynecological examinations, such as the smear test, was also normal. The infectious diseases came back normal, as well as the blood cell count and the clotting. We also tested the TSH, was completely normal, with a total level of 2.3. So in this slide, you may see I like that slide because it's a quite good way to see how the ovarian reserve reduces as the woman gets older. So it's important to consider that all women are born with a specific number of follicles that will be decreased according to age. So apart from that depletion of follicles, the AMH, which is the hormone that is best related to that ovarian reserve, also reduces. So that's the reason why you may see in this slide and in this picture how the ovarian reserve with the black line reduces as the woman gets older. So what's the karyotype? It's a really typical test that we also ask for. The karyotype is just an individual's group of chromosomes. It's an important test to be requested before IVF because it's true that almost 90% of the karyotypes we ask for are normal, but in some cases we find some alteration that could have an impact on the eventual embryos that we are creating at the laboratory. So that karyotype is used to look for abnormal numbers or structures of chromosomes that could have an impact in the embryos that we are creating, as I was mentioning before. The diagnosis in this specific clinical case was like a male factor and also age and a low ovarian reserve. Because of that, we decided and recommended our patients to undergo an IVF treatment with PGS, the pre-implantation genetic screening. We also recommended that patient that in case we have a good embryo and healthy embryo to transfer just one embryo due to her age. As we mentioned before, the impact that may have a twin pregnancy in a patient older than 40 years old especially could be an issue. So when we talk about IVF, it's called, we normally perform what we call ICSI, or intracytoplasmatic sperm injection, which is a procedure where a single sperm cell is injected into a cytoplasm of the mature egg. We use a tiny needle called micropipette and a holding needle or pipette. Which is completely necessary to use a microinjector to do that procedure, and we also need to prepare the eggs properly and sperm. In this case, we didn't need to use any specific technique for the fragmentation. As I mentioned, it came back normal, so we didn't need to use any specific technique. In this slide, you may see the different steps that an IVF includes. So the IVF protocol is also has to be started with a stimulation of the ovaries, as I guess that all of you may know. We perform ultrasounds and hormonal tests to see how the follicles and how the ovaries are working. And once we see that the follicles are big enough and also the hormonal tests are also fine, we perform the egg retrieval to get the eggs from the ovaries. And afterwards we need to fertilize the eggs and wait for 5 days to do the embryo transfer in case we decide to do so, or in this case, as we decided, we need to do the PGS, the pre-implantation genetic screening at that moment. So the pre-implantation genetic screening is the same procedure than a classic IVF cycle with various stimulation, as I mentioned, and a blastocyst stage biopsy prior to the transfer. So we do exactly the same, but the main difference is that we do not transfer the embryo at that moment, but we do the embryo biopsy on day 5 or day 6 of the embryo's development. The idea is selecting chromosomically healthy embryos. And it's known that it increases the chances of having a healthy baby because it reduces the risk of having a miscarriage, especially in patients that are older than 40 years old that have that risk quite high. And it also increases the probability of pregnancy per transfer. So that's another good reason to recommend a single embryo transfer in these patients. It also reduces the duration of the treatment and the number of cycles needed, because in the end, we are selecting a good quality embryo and also a healthy embryo. So the chances of implantation of that embryo are higher. In this slide, you would see the relationship between the oocyte, aneuploidy, and maternal age. So with the blue line, you will see how that chances of having a non-healthy embryo, which is called aneuploid embryo, is increased as the woman gets older. So that's the reason why we recommend performing an IVF with PGS, especially in patients older than 38 years old, which is the moment when the chances of having non-healthy embryos at the laboratory are increased. Of course, each patient has, the chance of deciding if they want to do it or not, but at least in the patient we are talking about today, we recommended it due to her age because she was 41 years old, and we thought that it was a really good option of, trying to increase the implantation rate and reduce, of course, the miscarriage rate if we do the PGS. So when we talk about PGS, the pre-implantation genetic screening, there are like three different types. The first one, which is the most common one, called PGT-A for aneuploid, detects loss of gain of genomic regions, studying the 23 couples of chromosomes. In contrast, the PGT-M, which is also used for monogenic diseases, detects monogenic diseases that can be transmitted from the parents. So we also use that technique, or we perform that kind of PGS when the patients are carrying a mutation that could be transmitted to their offspring. And the last one, and the less frequent one, is called PGT-SR, for structural anomalies. It detects alterations in the structure of the chromosomes, which is not the most common situation to be found at the laboratory. So in our patients, we retrieved 8 eggs. 5 of them fertilized properly, and we had 2 embryos developing into blastocyst stage. Both embryos were biopsied, and the results came back with the one euploid embryo, which was transferable and was chromosomically healthy, and one aneuploid embryo. So when we talk about euploid and aneuploid embryo, we mean that the euploid embryo contains 23 pairs of chromosomes, which is a completely normal embryo in that way. In contrast, the aneuploid embryo could have gains or loss of genetic material, and that's the reason why those embryos are not recommended to be transferred, because they could end in a miscarriage or in an affected fetus. That is what we want to avoid. In these patients, we offered a special test on the endometrium called Endometrial to maximize the implantation rate, as there was just one embryo that was available for the embryo transfer. So that endometrial test has to be performed with a mock cycle. We decided to do it with estradiol and subcutaneous progesterone. It could also be performed with a natural cycle, but it's important to consider that the cycle we are following for the mock cycle should be exactly the same as the one that we are using for the real embryo transfer. So in this patient, we offered both kind of cycles, and she decided to use them, and the one with estradiol and subcutaneous progesterone. We did an endometrial myopsy to check the window of implantation, which is called ERA. Also, the endometrial microbiome, which is called EMMA. And we also test the pathogenic bacteria causing chronic endometritis, which is called ALICE. The results we obtained was that both EMMA and ALICE were completely normal, so there was no chronic infection in the uterus, but we found that she had a pre-receptive endometrium, which means that the window of implantation, which is the moment when the endometrium is more receptive for eventual embryo transfer, was not in the normal and correct place. In this patient, the test told us that she needed some more hours of progesterone, at least one more day of progesterone. So they recommended to do the embryo transfer with 146 hours of progesterone. So with that test, we were able to personalize the embryo transfer, which is what we wanted. So the patient underwent the endometrial preparation for the frozen embryo that we had. She also used, again, estradiol 6 milligrams every day for 12 days. We tested the endometrium that was had a thickness of 8 millimeters. No dominant follicles in the ovaries were found. And we did the luteal phase support with subcutaneous progesterone, 25 milligrams, 1 vial every 12 hours, 6 days before the embryo transfer, as it was recommended with the ERA. We did, as I mentioned, a personalized single embryo transfer with also abdominal scan monitoring, and we did the beta HCG test 11 days later that came out positive. And now the patient is currently 35 weeks pregnant. Non-invasive prenatal DNA test was also performed as a recommendation of our genetic laboratory, despite we tested the embryos and we knew that the embryo was chromosomically healthy, it's also recommended to do a non-invasive prenatal DNA test to be as sure as possible that the baby is doing fine, because in the end we are not taking the cells from the embryo, we are just taking the cells from the external part of the embryo. And we know that the relationship between the external cells and the innermost cells that could be the embryo in the future are quite accurate, but it's also important to be as sure as possible that the baby is also doing fine. So we performed that non-invasive prenatal DNA test that came back normal, and no fetal or maternal complication have been found so far. So we hope to have really good news with the birth of this baby in some weeks. So the conclusions from our today's clinical case is that an accurate diagnosis and specific tests are essential for a correct assessment and proper treatment in our patients. It's really important to examine both male and female factors to have a good diagnosis and to be able to discard both factors and to know exactly what's going on with that patient. We know also that IVF plus PGS helps increasing the implantation rate, also reduces the miscarriage rate and shortens the time to get pregnant, selecting a chromosomically healthy embryo to transfer. It's also important to do a good endometrial assessment that could also play a role in personalizing the embryo transfer in these patients, especially when they just have one embryo to transfer and one valid embryo to transfer, and we just have one opportunity to do the embryo transfer. And as I mentioned previously, in advanced maternal age, it's important, it's really important to recommend our patients to do a selective a single embryo transfer to reduce risk during pregnancy, such as prematurity, preeclampsia, and diabetes. And thank you very much once again, and I'm open to answer all your questions. Thank you.
Thanks so much. Of course, that was another interesting case. So thank you for bringing this and taking us through the whole story, of course, from the very beginning about the diagnostics and, of course, the outcome. We always love those happy endings, right? So thank you so much indeed.
You're welcome.
All those details. As you can see, there are some questions. Some of those already are quite detailed. So let's get going. Let's start with our questions, okay? For all our patients. And just as a reminder, remember you can of course type this. We are happy to be able to help you and hopefully advice as well. Okay, so let's get going. I will start with the first question from Sam. There are like 3 parts of this, so let me go straight to it. And of course, I will be able to show you the whole parts as well. So Sam is 38, and my first IVF cycle produced 12 follicles. Only 1 egg was retrieved, and this did not make it past day 2. I was told I had cyst that's formed. My next round, I have been recommended a mite IVF. I have a fibroid which is 10 centimeters outside my uterus. Would you recommend single or 2 embryo transfer? Thank you for the question.
Thank you. So I normally recommend doing always single embryo transfer. So it's true that in the past we knew that at least if we transferred 2 embryos, it was like a thought that maybe one embryo could help the other one to implant. But nowadays it's known that if the embryos are good quality ones, in the end we are increasing the the twin pregnancy rate. So especially if you have also a fibroid in the uterus, that of course it's outside, that it's supposed not to have any effect on implantation, but in the end, if you have that fibroid there, I would also recommend just doing single embryo transfer always. So especially if the embryos, at least are not are good quality ones. In general, we always recommend doing single embryo transfer.
Thank you so much indeed for your very first question and of course for your help with that. Okay, let's have a look. Christina has another question again. bit of a longer question, so let me put those two right here. I'm 40 and have 2 frozen embryos when I was 40. Do you recommend other IVF procedures before I proceed with the transfer? Given that at 40, most embryos can be abnormal genetically. The embryos have not been tested. Also, do you recommend implanting one at a time or both of them at once? And let me just go to the next part. The frozen embryos are day 3. I was told it is best to freeze day 3 embryos if I only have a few. They told me that they were grade 1 embryos. What chance do these embryos have to reach blastocyst stage? Thanks.
Okay, thank you. So we know approximately that around 50% of the embryos that start developing on day 1 reach the blastocyst stage, but it's like in quite in a general situation. So it's impossible to know how the embryos may develop from day 3 to day 5. It's true, and we already know that in most cases, when a male factor appears, it could have an effect on embryos from day 3 on. I mean, if there is any problem with the sperm, it's quite typical that the embryos stop their development from day 3 on. So that's the reason why we normally recommend doing like the standard culture in all our patients to have like a good idea of how the embryos are developing, and also to transfer, if possible, the embryo that could have like quite chances of implantation. This is one of the things that I should consider. Regarding the transferring 1 or 2 embryos, as I mentioned before, it's true that the implantation rate of embryos becoming from a patient that was like 40 years old are not high. It's not high, but I would recommend doing a single embryo transfer anyway, because if there is any chance of having a twin pregnancy at that age, it's not good news. So if possible, I would suggest doing a single embryo transfer. I would say that almost in all patients, especially in patients that have advanced maternal age, because of the risks we have commented previously.
Again, thank you so much for your question, for all the details, and of course for your advice here as well. Okay, let's have a look. Flavia has had a question for you right here. We have 2 normal tested frozen embryos after 3 egg retrievals. My lining is thin due to ED in February. Any recommendations to help improve lining? We are considering PRP this month. I'm 39, were originally diagnosed with unexplained fertility.
So it's true that sometimes after some procedures that may affect the endometrial lining, it's difficult to make it grow. So it's possible to use different protocols, adding aspirin or sometimes pentosyphilin, trying to make that endometrium be thicker. So it's possible to try to do our best in that way. So we know that sometimes the uterus is difficult to deal with, but in the end we have different protocols, including estradiol, and also it's also possible to perform like a mild stimulation in the ovaries, so that the hormones that those ovaries will produce could also have an effect on the lining and could also help that lining be thicker. So there are like different ways of trying to have a better endometrium in that kind of patients. So there are different options and protocols, of course.
And again, thank you so much indeed for your question. And let's have a look. More questions are coming in, of course. Let's see. Next question is here. My biggest problem regarding embryo transfer has been thin endometrium and quality of it. Endometrium does not grow to have triangular structure, even though I have used 8 milligrams of Progenova per day. Do you have any suggestions? What could help to achieve triangular structure of endometrium?
Well, first of all, it's important to consider like adding some specific tests in patients with that thin endometrium. So it would be recommended doing at least an hysteroscopy that maybe that patient has already done, to be sure that there is any issue with the uterus, because sometimes we may find like the cavity is not big enough or so on. So sometimes it's important to discard some specific alterations in the uterus. Apart from that, if everything is fine in that way, it is also possible, as I mentioned before, to do a stimulation with low doses of gonadotropins, trying to make that endometrium be thicker. Apart from that, and apart from the Progenova, it's also possible to use the Progenova vaginal way, and we sometimes need to add aspirin in lower doses and also pentoxifylline or vitamin E. So, well, sometimes it's, we try to add different medication that we know that may have an effect on the endometrial lining. But I completely agree that sometimes it's really difficult to make that endometrium grow, but at least we have like different ways of trying to improve it.
And once again, thank you so much for your thorough answer to this question as well. And I believe it has been helpful. And let's have a look. Next question from Christine. If a woman ends up getting pregnant naturally before going in for IVF, is there anything she can take to maintain that pregnancy, such as progesterone? Any recommendations when progesterone levels are low?
Well, normally when a woman gets pregnant spontaneously, the progesterone level should be normal. Otherwise, that pregnancy wouldn't go on. This is the first step to consider. Apart from that, sometimes in patients that has previous miscarriages, sometimes we use progesterone with the aim of trying to to support a little bit more the luteal phase, and also that the progesterone could have an effect on the uterine contractions. So sometimes we use that progesterone to have that effect, but in general, when a patient gets pregnant, we just need, to do the scans that are needed and so on, and doing nothing special. Because we know that it's something, if a miscarriage is happening, we can't do anything to avoid it to happen in the end. So it's possible to use the progesterone in a very specific group of patients, but not in general.
All right. Again, thank you for that. And again, this is a question you already answered, but let's have a look, okay? If you can have a look at this. What are the rates of single versus double embryo transfer in patients over 40? Single embryo transfer is recommended.
Of course, it depends on the quality of the embryos, also on the personal history of that patient, on the number of previous attempts that patient has undergone. It's also important to know if the embryos are blastocyst embryos or day 2 or day 3 embryos. So there are like many factors that could affect the implantation and also the implantation rate. So if we are thinking in general that it's like a good quality embryo, especially if that embryo has been previously tested with PGS, of course, I would recommend 100% sure to do a single embryo transfer. In contrast, if we are talking about maybe an embryo on day 3, maybe like an intermediate or a non very good quality embryos, and maybe it's like, I don't know, the third time that patient undergoes that kind of treatment, maybe I would be like more flexible in maybe transferring 2 embryos, but just in very small group of patients, not in general. So in our clinic, we always do extended culture, and we always try to have embryos on blastocyst stage, and so it's quite typical to transfer just 1 embryo in spite of not being tested. So I would recommend, of course, we should know in that case that Sarah asks if we if the embryos are on day 3 or day 5 or so on. So it's not so easy as saying, okay, let's talk about rates, because we need to know a little bit more. But in general, I would say that if the embryo is a good quality one and it's a blastocyst embryo, we recommend transferring just 1 embryo.
And again, thank you so much, Sarah, for your question. Definitely, it's an interesting discussion, yes, when it comes to this. So thank you for answering that as well. Again, of course, but still, it's good to remind everyone about this, of course, as well. And actually, in regards to single embryo transfer, right? So you suggest transferring 1 embryo at a time. How often does a single embryo split?
Well, it's like quite uncommon. So it's like less than 1,000 approximately. So it's not very common to have that situation. But of course, it's another reason why, well, it's also a good way to recommend just transferring one embryo. So I remember the last year, I think that I don't remember any patient that had that situation. So any of the single embryo transfer that we did ended being like a twin pregnancy. I don't remember any of my patients at least, but of course it may happen.
Okay.
But it's like quite infrequent.
Yeah, okay, good to know, of course. Thank you, Flavia, also for that question. Definitely interesting one. And let's have a look, okay? Another question from Anelli. What is the suggested vitamin E dosage per day if I were to use it to boost growing of uterine lining?
We normally recommend between 400 and 800 milligrams every day. So the most typical dose is 400 vitamin E every day.
Okay, thank you for your question. Someone is typing. We need to give it a minute. I'm sure there will be more questions coming up, so don't hesitate. Go ahead. We just need to give you some time, I guess, so you can think about some other questions too. Remember, this is your time, and Dr. Marbán is for you, so don't hesitate. Use it, and I'm sure as you can see, she's brilliant at answering all the questions. So don't hesitate. And let's give it a second, okay? If not, we will be finishing. So, it's just your best chance to get some advice. But of course, also, I always remind everyone that there is a possibility for you to get in touch with Dr. Marbán and her team at Tambre Clinic. And I'm sure they will be happy to help you out. I know that they are quite busy right now. Lots of patients are coming in, but of course, I'm sure they will be happy to answer any of your questions. Again, I'm waiting for another one. So we need a minute. Yeah, okay. If you can have a look at this. I know usually doctors don't like to talk about prices, but if you can perhaps add anything.
I think it's the only question I can have an answer because I'm not very aware about money. But of course, as always, the price depends on the kind of treatment regarding IVF that the patient is undergoing. Because if we don't add, of course, the PGS is much it's cheaper than if we do the PGS, which is the most expensive part of the treatment in the end. So I can't let her know, the exact price because actually I don't know. I prefer not to know it.
I understand.
Just to be focused on my, on my patient and so on.
Of course, definitely.
That's also possible in case they want to have more information, as I'm not able to do that. It's possible that they write directly to the clinic, and I'm sure that my colleagues will be glad to answer them. So it's possible to write to information at clinicatambre.com, and they will be answered as soon as possible.
Exactly. So this is the best thing to do.
Yeah.
I'm always familiar with
that. So.
But it's good. Remember, there is a possibility for you to get in touch. You will be either redirected to the contact button, but of course you can always get in touch directly with the Clinica Tambre, and they will be able to give you provide all the details, I'm sure. So it's the best way. And okay, let's have a look. Flavia has another question. I'm doing acupuncture to help with thin lining. How can we prove this is actually helping if taking vitamins at the same time? Anything you can advise?
Yeah, actually, I think that the main problem with acupuncture is that we never know the effect it may have. So there are no serious and clinical studies that may help us in, making a decision in that way. The main reason is that when a patient undergoes and acupuncture, it's quite typical to have many other treatments at the same time, and it's not easy to know the specific effect that the acupuncture may have in the future and for the treatment and so on. So at least in our clinic, we normally use acupuncture for patients that, of course, want to use it to try, to be more relaxed and for the embryo transfer. But I'm not so sure that it could have an effect on the eventual endometrial thickness. So I would also recommend, changing the protocol the doctors are using, or trying to add, as I mentioned, aspirin or vitamin E or so on, trying, to help that endometrium grow. But I'm not so sure that the acupuncture could play a role in that specific situation.
Understood. Again, thank you so much, of course, for your advice on that as well. Okay, Christina has other question right here. Is PRP a good therapy for ovarian rejuvenation for women with low AMH and high FSH?
We are now using the PRP in patients with problems also with endometrium. We are undergoing a study to try to see if that PRP may help that patients to have a good, at least a better endometrium. And we are waiting for the results. So all the therapies regarding the ovarian rejuvenation is we don't use it in our daily practice. They are just in very specific, a small group of patients, and also for clinical studies, and they are not used for, let's say, like in our common practice. So as far as I know, there is no clinical evidence that a PRP could help in that kind of patients. But of course, we need to wait for the eventual results for the studies that they are doing now. But maybe in a future, I don't know when, we could have some news regarding especially patients that are really young and have that low ovarian reserve, and hopefully would have some news in that way. That, of course, could help us in having better results, especially in that patients.
Of course. Thank you so much indeed. That makes perfect sense. This is still something that is being, let's say, researched, so it's not commonly offered, at every clinic. So thanks a lot, of course, for bringing this today. And if you can clarify, because this is the same patient, can you use vitamin E and aspirin both at the same time?
Yeah, exactly. That's perfectly fine. And actually, it's the way we always do it, because we try, to push that endometrium, be thicker, and to do the embryo transfer as soon as possible. Exactly. It's perfectly fine to do. I want to use them at the same time.
Excellent. Thanks for the confirmation. And let's have a look. Sylvia has another question. If my last 2 IVF did not work out of the age of 43, to have a chance to conceive naturally is more likely? 0, right? The doctors are recommending me doing donor egg, but for now I am not ready for it. Any advice?
Well, I guess that Sylvia didn't undergo PGS. So it's true that it's quite likely that the embryos she transferred were aneuploid, and that's the main reason why she then got pregnant. So it's important to consider, in case she wants to try once again, because maybe if egg donation is not an option for her, which is something which is understandable. I would recommend, if possible, to do, to repeat the IVF cycle in case she doesn't want to undergo egg donation, and trying to do PGS on the embryos. It's also possible, if the ovarian reserve is low, sometimes we recommend doing what we call a dual stimulation, which is doing the first stimulation, retrieving the eggs, and 5 days later, at the same time as the embryos are being tested, it's possible to start a new stimulation with the aim of getting more eggs, and also to have more embryos in the bank, in the laboratory, to be tested. So it's recommended, especially in patients that we expect a low response because of their low ovarian reserve. But it's true that the chances of having healthy embryos at that age are around 10% maximum. So we should be realistic in that way. And of course, it's possible to try again, but we need to think that, the real expectations we are facing are not very high. So it's recommended doing egg donation is completely true. But I understand that sometimes things are not just thinking in the best treatment. But at least we could try to stimulate the ovaries again, and at least I would recommend doing the PGS to try to see if there is any healthy embryo to transfer afterwards.
Of course, thank you so much, and again for your advice for this question. And at least for now, it might be our final question. So of course, if you have any left, go ahead. This will be like a final call for the questions. And let's have a look. Okay, Flavia has another one. So any other vitamins you'd suggest taking to help with lining? I'm taking sorry. Yeah. Okay. Thank you. Vitamin D, vitamin E, prenatal, vitamin and fish oil.
Well, we know that vitamins in general, may help in, our general health, but the ones that at least have shown some effect on the endometrium is the vitamin E. Apart from other treatments such as aspirin, sometimes we also use Viagra to try to have like a better blood flow in the uterus. And we try, when we have to face a patient that that has that problem with the endometrium, we try to use as many different protocols as possible to try to make that endometrium grow. But for example, the prenatal vitamins and the fish oil and also the vitamin D do not have a specific effect on the endometrium. Of course, they may help in having the body in the best condition, but they don't have an effect on the endometrium themselves.
Of course. Thank you so much again. I do believe it has been helpful for you, Flavia, so you will know what to do. And of course, thank you so much, everyone, for all of your questions. I do not see more, but of course, as I've mentioned before, if you have any, you know what to do. You will be able to simply get in touch with Dr. Marbán, her team at Clinica Tambre, and I'm sure they will be more than happy to help you with any questions, of course, regarding the prices. Of course, it's best to get in touch with customer care. They will be able to tell you all the details there. And thank you so much, everyone, okay? Because we know that this is definitely not an easy topic, and we are here just to support you, to answer some of your questions, so give you some advice. And of course, Dr. Marbán, thank you so much for joining us for tonight, for spending this evening with us. And it's great to have you back, that's for sure. And I do hope that it has been also useful and interesting for you. And is there anything else you would like to add?
Thank you very much, Caroline, once again, because I'm really happy always to be here. So it has been a pleasure for me to have the chance of explaining that clinical case and also answering the questions, and I'm really thankful for you.
Thank you so much indeed. Okay, thank you, everyone. And of course, remember, it has been recorded, so you will have a chance to watch this on myivfenses.com. It is going to be available tomorrow, of course, on our site, but also on our YouTube channel. So as you know, there are over right now almost 400 webinars already on our site. So you can go check this out. And of course, you will be redirected to some previous webinars with Dr. Marbán as well. And you can have a look. It's been great to have you here, as I've mentioned. And I do hope to see you very, very soon. Thank you, everyone, and have a relaxing evening right now. And well, we will be back next week. So I do hope to see you here as well. Dr. Marbán, till our next event, okay?
Thank you
Hopefully
very much.
very soon.
See you soon.
Thank you so much.
Thank you.
Bye-bye.
Bye-bye.